The subcutaneous layer has been successfully incisioned. Now we'll use a bladder blade to protect the bladder peritoneum. Now we'll just open the loose visceral cell. Visceral means fat that gathers around your organs. We are trying to go towards through the uterus to the ovary to the amniotic sac where the baby lies. We will not cut a transverse dissection right there and stretch the opening laterally. Now there is the amniotic sac which you can see. We will now incise the amniotic sac and aspirate the amniotic fluid. I mean drain the amniotic fluid in, if you know what I mean. We can see the fetus, guys. We can see the fetus right now, so we'll just check for any complication that fetus is like entangled in the umbilical cord or something like that, which may be life threatening to the mother or to the fetus as well. And now we'll deliver the baby. Oh, this is so beautiful. This seems so beautiful. Have to cut the umbilical cord right now. We'll just cut between the clamps and then deliver the baby to the midwife or the pediatric team. Now we have to just put back the stuff that we have cut through and suture it. So this is a placenta. Placenta is a place from where mother nutrients from mother body enters into the kid's body, and it's kind of a storage. We will place swabs around the uterus and tie an anchor knot right there. Continual interlocking structures would do the magic. This seems right. Now we'll place the uterus back into the anatomical position. Anatomical position means where it actually resides. We'll confirm hemostasis. Okay, so we got a step backwards right there. We'll now confirm hemostasis and then go. Have to like suture it properly. We'll now suture the fibrous fascia. We'll confirm hemostasis at the subcutaneous level. Hemostasis means checking if their bleeding is appearing or not. Now as this is done, we'll now apply a bandage properly. That's it. And now we'll go towards the next operation. We'll select a local anesthetic now. This man's teeth and every kind of bone is like broken. He probably fell from some bike, had some bike accident, very bad bike accident. Now we'll be treating him. We'll start the incision at 5 mm above the teeth and continue the incision through the mucosa, submucosa, underlying facial muscles and peristernum into the bone surface. We will extend the incision properly and then start going through. We will select a sharp pedestrian elevator right now and deglove the anterior maxillary wall in a superior anterior direction. We will detach the nasolabial musculature along the piriform aperture. Dissect along the piriform rim superiorly until the lower extent of the fracture is identified. We will continue the dissection superiorly towards the infraorbital rim, taking great care not to overextend the dissection and avulse the medial carpal ligament. For the phase 2, we have to see for the fracture in the eye portion. First, we will cover the eye, the main eye, and we will select a 6.0 suture needle. We will pass the suture through the skin of the upper eyelid and subsequently through the grey line of the upper lid margin. We leave some space between the skin and outline the planned incision. We will insert the skin along the marked portion and place two small blunt retractors. We will proceed with the dissection right there. For the phase 3, we will reduce the frontal process of the elevator right now and verify the reduction of the level of the piriform rim. We will select the appropriate mid-face plate for the suture. We will contour the plate to fit the patient's anatomy using the bending pliers. Ensure the plier is passively adapted to the bone. We will place the plate as a frontonasal suture and confirm the plate positioning allow for adequate clearance of nerves and any other critical things. We will drill through the first screw hole. We have to apply screw towards all the process. We are selecting a 1.5 mm screw right here and insert the first screw close to the fracture, then tighten until secure. We will insert the second screw on the opposite side of the fracture. We will place and fix the second plate at the nasomaxillary buttress with the same technique as before. Check for hemostasis and indicate the wound size. If necessary, use bipolar diathermy. We will close the frontonasal suture region layer by layer with 5.0 reservable sutures. Nice. For the phase 4, we will retract the soft tissue and incise the periosteum. We will select the periosteal layer to expose the suture from above. And we will elevate it properly. Now we will just applying the local anesthesia at the lower eyelid and inside the skin along the marked path. We will develop a skin flap inferiorly. We will butterly dissect the screen right now and extend the dissection of the suborbital. We have cut very deep through that. You can see the damage there, right? You can see the crack. Right, doing properly right now. I have to apply the screws right there and plates again. We'll apply and fix a second plate. And irrigate the one sides properly. We'll close the laceration and ciliary wounds layer by layer with resorbable 5.0 sutures. We'll staple a drape to the skull posterior to the corridor of incision. We'll select a number 10 to 15 blade. We'll continue the dissection anteriorly 2 to 4 cm in the subgaleal plane. We'll applying flaps right there. We'll select curved scissors and insert the curved scissors inferolaterally in the subgaleal plane through the incision and towards the auricular helix until the tip reaches the insertion area of the zygomatic arc. Have to do it properly. We have opened the skull right now. We'll carefully coagulate the vessels and extend the incision bilaterally. Wow, really didn't need to open the whole skull just to fix this. It's too many damage right there. We'll apply as many plates as we can. We'll now verify it. Just wiring the portions and wiring the nerves. This is the last one, I guess. We'll create a hole through the ethmoid area posterior to the lacrimal crest from the contralateral side using a spinal needle or drill. We'll detach the swagged on needle from the wire. That's perfect. We'll perform a force reduction test to ensure that the orbital floor implant has not been impinged on any structures and decrease ocular mobility. No ocular mobility, then eye movement is okay. We'll irrigate the surgical sites right now. We'll revert the coronal flap and remove the Rene clips. After ensuring hemostasis, we will use the sutures. We are using a stapler this time. So this is it, guys. We are going goodbye.